Welcome. I'm joined today by Dr. Jeffrey Anderson with the Intermountain Medical Center Heart Institute in Salt Lake City, and we are talking about some of the late-breaking trials that are at the American Heart Association Scientific Session. This year, we understand there's over 30 trials that will be presented as late breakers. Talk to us about some of the exciting ones that you have looked at and are excited about.
Well, one trial I'm excited about to learn the results is called Daycap. And this focuses on preventing clots in patients with coronary heart disease. Okay. So traditionally, we've used aspirin as an antithrombotic that inhibits platelets. And so all the new agents have been added on to aspirin. But the question is, do we really still need aspirin? These newer agents are very effective, and having too much on board increases the risk of bleeding. So in Daycap, they've looked at patients after coronary bypass surgery that traditionally had just been given aspirin, but here we're giving a new drug instead, ticagrelor, with or without aspirin, to see whether we can just get away with ticagrelor alone without aspirin. I'm very excited to hear
what are the significance of those findings?
Well, I think if we can cut down the risk of bleeding by giving too much and still preserve the antiplatelet effect or prevention effect on clots, that's an advance, and we're looking forward to that.
Great.
Another trial I'm quite interested in is called Bleomycin Control 2, interesting title. And so when we as electrophysiologists put in pacemakers or defibrillators, we incise the skin, we make a pocket, there's a risk of bleeding. And many of these patients are already on anticoagulants.
Okay.
And the question is, do you stop the anticoagulant beforehand and cover them with heparin in the meantime, or do you just keep going with the anticoagulant? And with Coumadin or warfarin, that's the most common anticoagulant, turned out that it's just as good or better to just keep going with the warfarin, not interrupt it and bridge them with heparin. We're now using a lot of the newer anticoagulants instead of warfarin. They seem to work at least as well or better with lower bleeding risk, but can we do that with these agents? Can we keep going, or should we stop and bridge them with heparin? And I'm waiting for the answer from the Bleomycin Control 2 trial.
Significance of those findings?
Well, because we want to make sure that we don't run the risk of clotting in the meantime, strokes and so forth in these patients are higher risk. And on the other hand, we want to reduce the risk of bleeding associated with putting the device, we call them pocket hematomas. And so it's a very important question.
Great.
A number of the trials are investigating treatment with new anti-diabetic drugs, and this has been an area of growth. And this area, class of drugs, is called sodium glucose cotransporter 2, or Sglt2 inhibitors.
Okay.
And what that means is that this new approach to treatment diabetes, instead of targeting the pancreas or the liver, targets the kidneys. So what happens is it blocks the reuptake pathway for sugar, for glucose, and so it actually goes out in the urine. And that's the way it is used to control diabetes. And this class of drugs has also now recently been shown to reduce your cardiovascular risk, which hasn't been really true of the older diabetic drugs. And so that's very exciting. And so these trials look at a couple of these drugs, canagliflozin and empagliflozin, and various populations, primary and secondary prevention, heart failure, and also peripheral arterial disease, that will teach us how we can best use these drugs and actually impact outcomes.
So the potential impact for this study is significant.
It is, not only reducing glucose and controlling sugar, but also improving outcomes as well. Another very interesting study is Cantos, and the primary results have just been presented, but this study looked at the hypothesis that reducing inflammation with a very specific anti-inflammatory drug can also reduce cardiovascular outcomes and risk. In addition to reducing cholesterol, we know that that already has been useful. And so in this study, a new hypothesis is being tested and being presented. That is that we look at each individual's inflammatory risk as marked by C-reactive protein, and then their cholesterol risk as marked by LDL cholesterol, to see which of these treatments works best in patients that have varying degrees of residual inflammatory risk versus residual cholesterol risk. So should we push on lowering cholesterol more, or should we push on an anti-inflammatory effect with this drug is called canakinumab, where there might be alternatives to that approach to see how we can best reduce the overall residual risk in patients with cardiovascular disease.
Very exciting. Thank you.
Well, a couple of other interesting trials relate to what we call regeneration therapy. So this has been around for a while, but it's never really been shown to be clinically impactful yet, and that is to use stem cells, cardiac stem cells, to improve function in patients with heart failure. And we're looking very much forward to the results of the All-Star study, which uses a particular kind of stem cell to see if we can improve the heart function in those who have heart failure. Really exciting. And another one targets a genetic disease, Duchenne's muscular dystrophy, that also affects the heart. And in this study, they've generated a specific kind of stem cell that we think can be helpful in these patients that have a genetic defect in their muscle cells. So I'm looking with great interest to the results of the Hope Duchenne study.
Thanks, Dr. Anderson. We appreciate you being with us. We invite you to join us at the Intermountain Medical Center Heart Institute booth for information about some of the abstracts that we have produced at this scientific session, along with some commentary and thoughts on late-breaking studies as well. Thank you so much and have a great day.